I'd like to share a case that I encountered a couple of years ago. It was an interesting case for me as a spinal cord physician. A 38-year-old male with a past medical history of having a spinal cord injury sustained from a gunshot wound for 8 years was referred to me for his spinal cord injury rehabilitation. Uh, one of the um, one of his big major problems was this persistent, severe left-sided abdominal pain and trunk spasms. So he had his spinal cord injury in the thoracic area in the left T10 level, and that was where he had a retained bullet fragment lodged. He had been to Before coming to me, had been to different providers, had undergone an extensive workup with the gastroenterologist, colonoscopy, um, esophageal studies, etc. But they could not find um, what was the reason for his pain, aside from the fact that he did have neurogenic bowel stemming from the chronic spinal cord injury. I had repeated his CT myelogram, which did show a very impressive bullet fragment right smacked at the left T11 pedicle, and that bullet was encased in osseous remodeling, which speaks to a hypermetabolic state at that point in time, probably. And there was severe left T10 to T11 neural foraminal narrowing. Honestly, I was at my wit's end when I had ordered for a lead level just because we never checked and I had no idea what type of bullet he had. Perhaps having, increased or elevated lead levels is the one reason why he was having this abdominal pain, which we could not explain. And it turned out that his lead levels were quite high. So it was at 63 micrograms per deciliter, and normal is at around less than 5 micrograms per deciliter. Eventually, we were able to get in touch and coordinate with a surgeon who removed his lead who removed the bullet. And we've been tracking his lead level since the removal of the bullet. It is currently going down. It's been plateauing from 63. Now it's like around 44.6 micrograms per deciliter. With the removal of the bullet, unfortunately, it did not guarantee a improvement or resolution of the left-sided abdominal pain and trunk spasms, but the patient did state that he felt a little bit less irritable now since the removal of the bullet. For me, the lesson learned as a practicing clinician is in this situation, after you've ruled out the most common and probable um, differential diagnosis, lead toxicity should, you should include lead toxicity as part of your differential diagnosis for abdominal pain in patients with a significantly retained bullet fragment.